So it's week 6 already. We're halfway through. Excuse me. Next week is going to be exam 2. You know, this week's are all those reviews. So far, you have 3 different review recordings posted. More are coming, one tonight, one tomorrow, and I believe Sunday. So they're all over the place. Know that it's only in one announcement. I just keep editing so you don't have to look in 7 different places. This week, we're going to be doing hematology, immunology, and then the child with cancer. And your assignment, you do not have a discussion question this week, so you get a break there, but you have CJ SINs and you have your NCLEX questions. So that's what's due. Now, I highly recommend you think about what is going to be your pediatric assessment. Community assignments coming up, and so does this, which is more time consuming because it is 6% of your grade. So I know next week after the exam, once you get it done, you know, or even as you're studying, maybe pick something in weeks 4 through 6, right? Maybe that diagnosis will help you through the exam. So, you know, see what you can do, send it to me. I will pre-grade it, send it back, and I will let you get a higher grade. I'll rescore it higher if you fix everything, so you can get the best grade. And I do it like that because many of you are going to go on in your careers, and most of everything is papers. Bachelor's, master's, and PhD, they're all papers. So if I can help you a little bit on how to write them, I'm going to be saving you a lot of anguish later on as you go through school. So that's why I do it. And Dr. Brown knows I do it, so it's okay. So any questions? Let's go ahead and start with.
I'm sorry, Professor, I had problem with Kahoot. Is that? What happened?
I thought it was mine.
I think she's having trouble with her internet.
Yep, we lost her
I was gonna
again.
say, it must be the weather or something.
Yeah.
I'm going in and out.
Yeah.
And I'm hardwired into my computer too.
Yeah.
Yeah, I was asking you a question about the Kahoot.
Okay.
I couldn't, for some reason, it was asking me to register.
You don't have to register. Just take it and put it in the URL bar, and that usually works. Instead of clicking on it, just pull it up, copy it, put it in the URL bar, and usually that will give you it right to where you want to go.
Okay, thank you.
And if you need it reposted, just let me know. I'll repost it. It's not a problem.
Okay, thank you.
You're welcome. So hematology, immunology, we can really tell a lot by just a CBC. We can look at white blood counts. We can look at bleeding problems, anemias. We can look at all things, even cancer, simple CBC. History and physical, very important. When we see anemias, we know that the blood counts are low. The hemoglobin and hematocrit are low. Now, the hemoglobin, red blood cells, carry oxygen and iron. So when you don't have enough cells, those cells in the body, right, this oxygen and iron, it's not there. So the body gets tired really quick. If you see a child who's starting with fatigue, right, tires easily from infants up, right? We know that something's going on. A simple CBC will tell us. Now, think about the toddler. The toddlers are picky eaters. They're finicky. We've taken them off iron fortified, formula or milk, right? It's whole milk now. That's probably your most at-risk child because of dietary for iron deficient anemia. So think about that as we're talking about these anemias. And of course, immunology, we're seeing infections, and then we're going to go into some bleeding. So as I said, anemia is not enough cells. Oxygen, iron aren't there, and the body doesn't like it. They usually stay at 10. That's the cutoff. And below that, they're calling anemic. But again, remember, it's symptomatic. How the child, are they symptomatic or not? That will determine what we do. Now, if we have a child with anemia, we have a lot of fluid. So you hear a lot of swishing going on, especially in the heart. You will hear a murmur. It's just a swishing of the cells through the valves. And you do hear trying really hard to get whatever oxygen there around. And you're going to hear all of that swishing going on. And if we let it go too long, the heart will go into failure. It gets tired. It says, okay, I've had enough. There's a lot of different anemias. B12, this is one, this is the intrinsic factor. So the one thing with B12 is the diagnosis of it. It's a big, red, beefy tongue. That's what you would see if that's what's going on with nutrition. Iron, we know you're pale, no energy, fatigue, right? Then we get into the cancers, aplastic anemia. We get into that blood loss, whether it's through epistaxis. In fact, nosebleeds, a lot of the times, tell us about underlying conditions like ITP. We'll go into that. And then, of course, there's those cells that just burst. In pharmacology, you might or might not heard of G6PD syndrome, whereas the body doesn't tolerate sugar. And if you put sugar in the body on medicines like what? Tylenol, Motrin, they're all sugary, right? It'll cause the red blood cells to burst. So that's one of those hereditary things. And then, of course, it goes into overall infections, etc., or because of the using chemotherapies. Diagnosing, well, it's the history, it's the physical. The kid was active, alert, and now they're sitting in a corner and they can't move. Or now the baby's not eating as much as they could and they're huffing and puffing and falling asleep. All of these things are part of that history we'll want to see. If we need to, we're going to be replacing these children, giving them blood. Now, the blood is given, remember, it's normal blood transfusion reactions we're concerned about, right? When we're talking about supportive care for anemia, this is just giving some fluids to the child. And then they say give some oxygen. Now, if you give extra oxygen, does it mean more oxygen goes to the body's cells? There's no cells. So again, it's controversial, isn't it? But they do it because, it seems like the right thing to do, right? And then, of course, rest, conserving energy. Now, we can look at a lot of these children and we can figure out what is happening just by sometimes the age or the racial background. African American sickle cell, right? Mediterranean descent, that's going to be thalassemia. We'll go into that. That's going to give us clues. And of course, that history. And then the one thing we need to rule out is, are they having a GI bleed that nobody knows about? That's why they're anemic. So a simple stool for occult blood. Rule out the obvious. Don't go directly into the big diseases, right? We know children, and we're talking about anemia. We're going to be checking blood, right? So we need to prepare these children, keep them as calm as possible. And, during the time when those hemoglobin hematocrits are low, to try to space out their care. Don't overtire them. So iron deficient anemia, most common of all, right? We know that at least under a year old, they're getting iron fortified formula, iron fortified cereals, or we're giving them vitamin D, the breast milk, they're getting all what they need. Well, we know then at toddlers, we start that whole milk, and that's that milk babies thing. It's because they're not getting the iron. And yes, they're getting the fat and the carbs, but they're not getting the iron, and that's what's considered that milk baby. So how do we treat iron deficient anemia? Well, we don't go directly to giving them vitamins. We start with dietary, right? So we need to increase all of those things in the body that's higher in iron. Now, if that's not working, or if it's so severe, the physician says, let's just put them on iron supplementation. We have iron dextran, that is that Z-Track iron injections. We give it Z-Track because it burns and it stains the skin. So it keeps it inside the muscle because it's like I call a lock and load. Pull the skin, push it in, needle out, and you like lock it, and then it's covered and it won't ooze out. Remember with iron orally, it does stain the teeth. So whoever, what age, it doesn't matter. They're taking oral iron, they need to drink it through a straw because it's gonna worry about the staining in the teeth. Also, it is recommended to drink it with orange juice because iron is metabolized in the stomach because of gastric acid. Orange juice adds extra acid. So then it's made into a now let's just do sickle cell and what is it? Well, sickle cell we know is those little weird shaped sickle cells, right? And they go down to a bifurcation in a vessel. And if it's not diluted or plump enough, it's going to get caught at that bifurcation. And then all the cells go behind it, causing swelling, causing pain, and distally could even be causing cell death necrosis, right? And it hurts. So how are we going to treat sickle cell? It's a block up of vessels somewhere. Could be in the brain, that could be a stroke. It could be in the chest, it could be a myocardial infarction, it could be in the lungs, pulmonary embolus. So wherever that pain is, think of other conditions it could cause because sickle cell can do that. Now, how do we stop the pain? Well, the vessels are small. The cells can't get through. We're going to priority. We're going to be giving big boluses of IV fluids, dilate the vessels, and we're going to put heat on it because that dilates too. Now, on the other hand, I have the pain medicine, but it's the fluids which will stop the cause. The pain medicine only treats the symptom of pain, okay? Now, what causes sickle cell and these crises to go on? Well, it's that dehydration thing. And we know if you're sick, have a fever, guess what? You're burning up more fluid. So fever is one of the big cause. It could be a stress. I mean, all of these immunosuppressive diseases, stress causes everything with them, causes the pain, etc. You're not eating, not drinking. And we know that sickle cell, the prevention is what we want to do, especially with children, keeping hydrated. One of the things that I didn't think of, and as I was doing reading, is when you go up in an airplane, you're in a pressurized cabin, right? Guess what happens to the vessels? They shrink, they get smaller. Guess what? You're at possibility of a sickle cell. So any child, adult, sickle cell should really overhydrate before getting on a plane. That's something that I've learned. We're doing sickle cell screening on all children. What's the first thing we see with sickle cell? With these children, it's usually we start seeing their hemoglobin crits going down, and then we're looking at the cells. Because remember, at birth, we have mommies. We don't see it right at birth. It's a little bit later on. We able to build up. Hydrate, 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 hydrate. Heat also, dilate it, get those vessels open, make that clog move. And of course, that analgesia for pain. They use morphine, hydromorphone on these kids, and they need it. They're in tears. They're just, it's really sad to see a kid in sickle cell who's in a severe crisis, and they hurt. And we'll give sometimes multiple doses just in the emergency room. Now, another thing is they have problems with electrolytes, potassium, sodiums. So looking for that, we might have to replace it. And sickle cells die quickly. So what does that mean? When you have a kid who comes in for a sickle cell crisis, usually their hemoglobin hematocrit is less than 7 and 21. In all my career, I've never seen one higher than that. Usually at 5 or 6. So what are we doing? What's our priority with that child besides fluid? Because now you're dilating and diluting all of the cells that are there. So probably you started out with a 5 hemoglobin. It's now down to 3 with fluids. You have to put blood in there. They need blood. They need the red cells. So in the ER, they're starting blood immediately on these children. Also, because a lot of the time it's infection that caused it, we'll be giving IV antibiotics. Now, to try to help prevent, these sickle attacks, well, of course, is hydration and rest are things that must be these children and parents need to understand. They can't go now, they can go play soccer, but they have to hydrate and they have to take some time on the bench to rest. Even the best guy, right? Because their body needs that. And then they'll be able to play the whole game and they won't be getting these sickle attacks. Now, when we know that these children are sickle cell, we're going to be giving prophylactic antibiotics. PenVK was always the one that I saw in my hospital, but it's an antibiotic, penicillin, from 2 months to 5 years old. And that's all prophylactic. Because remember, babies aren't born with an immune system. So let's give them something to try to fight so it doesn't get too bad, right? Also, we're going to be monitoring retic counts. We want to know how the body is working. Is it producing cells? And then, as I said, blood transfusions are given. It replaces red blood cells and oxygen, and it's what it needs right away, fluids and that dilation of those vessels. Now, there's no cure. Usually, they die from this bacterial infection. That's why they say any immunosuppressive disease that has a fever of 100.5 or higher needs to call their healthcare provider. They need antibiotics. Remember, you're immunosuppressed. You don't have an immune system. So you need that antibiotic as soon as you possibly can, right? Now, usually, people do live up into the 50s and more. As long as they keep hydrated, top of themselves, get the antibiotics as they need, take care of their bodies, they can do really good. So again, early intervention, penicillin, as I said, remember, there can be strokes, respiratory problems, be aware, and treat these kids normally, but make sure that they know the guidelines. Hydrate, rest, hydrate, rest, right? If they're going to be doing these activities. Now, thalassemia is a disease. This is one from the Mediterranean descendants. And this disease, I call it the rectangle shaped cells. And the problem with them is they're abnormal and they burst and it's a very short life. And their body only produces these rectangular cells that burst and they die. Now, there are here, you'll see multiple types of thalassemia. When we talk about thalassemia, like in exams and HESEs, etc., they're talking about Cooley's. They're not talking about the moderate stuff. Okay? Cooley's anemia is when it gets to the point where the body is producing only bad cells and they need transfusions to live, period. So these children will be going once a week, every 2 weeks, whatever it is, going getting their blood transfusions. And if you can imagine how many antibodies and weird things they pick up in blood, eventually it's going to be hard to find blood for them, right? So when do we find thalassemia? Well, as I said, those blood cells at first are moms, so we don't see them initially. It's now they start seeing changes about 6 weeks of age. And the way that we look at it is, now you're anemic, you don't have energy, you're not eating. What happens with no nutrition? No nutrition, you're not going to grow, and cognitively, you're not going to be where you should be. And that's why they usually will check the CBC to see what's going on. The body tells all, as long as we know those stages, right? Now, as I said, thalassemia is that bursting of cells. And in the cells is oxygen and iron, right? Well, it's so much bursting of cells and so much iron, the body becomes toxic with it. So we have to give either an iron chelating drug, take it orally, it goes to the kidneys, it gets rid of the iron, or we do something which is similar but not like dialysis, called apheresis. And apheresis is run by nurses, and it pulls off just certain components out of the blood. And what it does is pulls off iron if the iron chelation medications aren't working. So goal is compliance, compliance. Also, these kids are sick. They're always blood up, blood down, blood up, blood down. Can you imagine the heart? Can you imagine activity? Oh, I'm really busy, and then, oh, I can't move. And now I'm just, got my blood, so I'm good. And then I'm tired again. So it is a chronic in and out of physicians, into treatments and getting transfusions, etc. Also, it's that concern of multiple blood transfusions. It's up just blood transfusion, and then the cells die. And then you get all the blood, and then they die. The heart doesn't like that yo-yo back and forth, because when you don't have enough cells, the heart beat, 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 and then it stops, right? When you get the blood and beats normally. So it gets tired. So heart disease is a big thing with it. Many times they'll remove the spleen to stop those cells from being produced. But because of the immunosuppressed again, it's that septic shock, that total body sepsis post-splenectomy with multiple organ failure that will kill them. And again, maybe a bone marrow transplant is a cure, but it's not there yet completely. Now, aplastic anemia. This is a depression, and we usually, when we talk, is the pancocytopenia. Okay, the first one is profound anemia. So hemoglobin, hematocrit are low. Leukopenia, low white blood cells. And then thrombocytopenia, low platelet counts. So what's happening to this child? Well, they're tired, they're fatigued, they're leukopenic, so they're really set up to get an infection. And thrombocytopenia, not enough platelets, they'll be bleeding, petechial, bruising, something's going on. So that's a whole body. They treat it like leukemia. They give the chemotherapy units on it, immunosuppressive therapy, and bone marrow transplant to try to correct it. Now, bleeding things, defects in hemostasis. And when you think of bleeding, you always think hemophilia, right? Factor VIII, and it is a trait of X-linked recessive. It's for mommy. So you have hemophilia A, B, and von Willebrand, which is the blood has many things that help the blood clot. There's many elements. There are factors. There is a von Willebrand, which, of course, it was a scientist named von Willebrand found it. And then there's like platelets also, which also help. So there's a bunch of stuff that's there, and you need all of it to work. Now, Factor VIII, most common. Factor IX is Christmas disease. It's, it's there, but 8 is the most. And then von Willebrand and factor 8. That means two different components. Are there. I've actually seen more had a problem. Well, we just give a factor, they'll be fine. Well, what happens with hemophilia? All of a sudden there's bleeding. And if it gets into joints, hemarthrosis, it can cause joint damage. It just eats up the joint lining, right? Bruising, and it just gets bruising, bruising, bruising. The bleeding doesn't stop. And the thing with hemophilia, these kids, if they didn't know it before, they're coming in with these bruising, these bleedings, and what they'll do is just a set of blood tests. Now, if they think it's hemophilia, maybe their mom had some sort of past history, familiar history, what they'll do is they'll pull the factors, but those take about a week to come back. But they'll pull a PTT, which is what we measure heparin with, right? And platelet counts, and then parathyroid and fibrinogen. Those are other ones. But the PTT and the platelets are the ones that we look at, and they're prolonged for no reason. Kid's not on aspirin, there's no reason for it, and that is going to be our suspicion. So, what do we do when a kid is bleeding? Well, you replace the factor. I have seen some beautiful home infusions. Actually, they came to my ER. It was a father and a son, and he was 9, and he actually had fallen down onto his knee, and it was swollen, and it was really ecchymotic, and they couldn't get a hold of their hematologist, so they came into the ER, and our physician said, "Yeah, give it." And dad and the son said, "Do you mind if we give it?" And I'm like, "No." And I just said, "Can I watch?" Because I had a orientee with me. So we watched this father, the best care I've seen. He washed his hands. He set out the medicine. The son picked the vein. It was a butterfly needle. Put it in. He had mixed it up, put it in, and it was done in 20 minutes. And it was very well done. I was impressed. So it can be given at home and it can be given by dads really well. Now, that is when you have those factors. Now, sometimes you're mild. It's not as severe. Sometimes desmopressin, which next week we're going to learn is also diabetes insipidus, we use it for, but it's also used for hemophilia. And then sometimes there's amycrepoic acid that we do. Management, hemophilia. Well, what if you find out your toddler has hemophilia? Remember, they're clumsy, they're bumping and everything, they're exploring the world, right? So instead of just rice, if there is a coffee table with sharp edges, anything that could cut this kid, pat it, tape it, do whatever has to be done. If something happens at home and they're bleeding, number one, sit down, rest. Ice it, which means constrict those vessels so it doesn't bleed. Compression, right? You put your finger over something's bleeding, it's going to stop it or decrease it. And of course, elevate it above the heart, and that will also decrease bleeding. Our goal is to prevent long-term damage because of the blood in the joints. And they don't have to be in wheelchairs. They can be normal children. There's no reason. Now, this kid might be the one who goes on the swim team or maybe the bowling team. They may not be playing things like football because they get hit, they're going to bleed, but they still can be normal kids. And this is something they're working on a gene therapy with. We're close to those things. Now, I mentioned ITP, which you sometimes, and actually every time I've seen it, that they didn't understand they had it, it was because of a severe nosebleed, epistaxis. So child's coming in with epistaxis, then we look at the body and we find this purpura, these little purple little bruising and ecchymotic area, and we're like, So we start asking questions. Well, usually these children have had some sort of upper respiratory or some sort of infection. Could be influenza. I mean, something's gone on, and now the body, it's going into an acute stage of immune thrombocytopenia purpura, ITP. P, platelets are low, okay? So ITP, P is for platelets. So it can be turned around and it can be, quote, cured. After a year of having it, though, they call it a chronic. Treatment is just primary supportive, which, rest and good nutrition, but IVIG boosts the immune system and some anti-D can help. Now, you get a child admitted, that has this acute stage of ITP. This is teaching them about the treatment and preventing them from making themselves bleed until we get these platelets up to a level. Usually these platelets are below 20,000, usually closer to 10,000, and they bleed. So in the hospital, no unnecessary venipunctures. You're going to be watching for bleeding, for purpura, for nose bleeds, gum bleeds, urine. So they'll usually will be doing daily CBCs. Is the treatment working? What are the platelets today? And they usually will pull that off the IV. So it's not like they're getting sick every day. So monitor those CBCs. And then steroids, corticosteroids sometimes, but many times are prescribed in order to help the body recover and let the platelets, make more platelets in the body. So epistaxis is one of your NCLEX questions you'll see also. One of the things about epistaxis is all of a sudden a kid is bleeding profusely out of their nose. Remember, they think their body parts are coming out and they're just going to die. So they're like going bonkers. They're so upset, right? So number one, calm the child down. Have his thumb and forefinger pinch the base of the nose and have them lean forward. Now, some of you like to go backwards. Well, you're just making that blood go down into the stomach, and now they're going to be vomiting blood, and then they're going to irritate the nose and continue the bleeding. So it's forward. Let the blood drip out of the mouth, okay? If after 10 minutes it's still bleeding, they need to get medical care. Sometimes they have to cauterize, sometimes it's tampons, or maybe finding why are they having that epistaxis. Maybe it's a new onset ITP, right? HIV and AIDS, two people in pediatrics we talk about. We talk about the infant because mom had it and passed it on, or we have that adolescent doing risky behaviors, even they know better, right? So one of the things about HIV, AIDS, and infants, our goal is to improve their immune function. We'll be giving antivirals. Now, I had the opportunity to see in triplets. There was 3 of them, all girls, and it was from an HIV positive mother. One had HIV, one of the triplets, one had AIDS, and one child was free of HIV, had nothing. So it was the different bodies' responses. I've also seen them born at birth HIV and convert negative by 1-year-old. So HIV does not mean a sentence to a newborn infant, as long as we aggressively treat them to improve their immune system. We know pneumocystic pneumonia is the most common respiratory problems with HIV. So the treatment of hematologic immunologic disorders, well, we know we're going to get blood transfusions, whatever type of blood they need, and we got to follow protocol. Apheresis is like when we take and remove the iron from that thalassemia patient, right? Sometimes we go and get platelets from donors to give to that ITP person because maybe they need it. Sometimes they do. And then bone marrow aspirations. Remember, we need to see where those cells are being produced and what they look like. Now, I don't know if you've ever had the opportunity to look at a bone marrow aspiration done, but that little blue thing, they go into the bone and it's uncomfortable. Now, with children, if they tell you, is it gonna hurt? Be honest. Yes, it will hurt a little, but we're doing everything to make it as little as possible, and I will hold your hand. If a kid knows what to expect, they're not going to be as scared as you telling you, no, it's not going to hurt. And as soon as they put the needle down deep, that's when they usually hurt. Although we are doing deep infiltrations now. So if a child, parents have sickle cell, only the trait, what's the chance that each of her children will have sickle cell? Anybody?
Is it 50?
It's 1 in 4. It's 25%. Just to let you know. It's okay. I don't mind a guess. A guess is better than nobody saying nothing. So neoplastic disorders, leukemia and lymphomas. These are blood and blood-forming organs. Now, leukemias, there's the ALL and AML. It's a different sort of white cells that are there. It's more frequent in boys, ages 2 to 5. But today, survivability is better than it has ever been. It used to be the death sentence many, many years ago. What is leukemia? Well, the body makes white blood cells, but they are immature and they just don't work. And it is a cancer. Okay, so you're producing cells, but it's not working. So, how do you diagnose leukemia? Now, I had a neighbor. She was, usually these are younger kids that you see it in. She happened to be 12 or 13 at the time. And she was complaining of being tired, having a fever, having bruising, and she was having severe knee pain. Went into the ER. They looked at her, they drew a CBC, and her original white blood cell count was 0.1. It should be 7 to 10, right? That's your normal type of range. It means no white cells, no immune system at all going on. This is many years ago. Today, she's a PhD from the University of Miami. I mean, she's brilliant. She came through it with flying colors. But at the time, I remember being devastated because I've known her for many years. She was one of the kids on the blocks that I took care of. They were always at my house. And so the parents would come over and check on me too. But it was those symptoms, type of symptoms that you will see, okay? So when they did the CBC and pulled it, that white count was that low. But you're also going to, when you determine that, you do a smear. And that blood smear will show all of those immature cells. So then there it is. At that time, the lumbar puncture needs to be done. Is it in the central nervous system? And then, of course, your bone marrow biopsy. And as I said, be honest, it hurts. Now, they're going to insert some sort of permanent port. Usually it's the port that they put in right underneath the skin. And all they have to do is numb it with and put a Band-Aid on it to come in when they need to. And they feel touch and no pain. And it works for the course of the chemotherapy. Now, the first 4 to 6 weeks of chemotherapy is intense. All the side effects, they're all there. And that's the first 4 to 6 weeks. The chemo eradicates the chemo in the body. all of the cells, all the cancer. They're eradicated. So our goal is remission, but then they'll do intrathecal, central nervous system to be sure. Then they're also going to go and do a little more to make sure there's no hiding stuff around. And then, of course, the maintenance, just to be sure that no sneaky little cell was hiding, comes back, and there goes the cancer again. Now, we were talking about transplants as rejection, right? Well, we talk about the hematopoietic stem cell transplants, bone marrow transplants, right? This is the one that infection is your biggest cause of death. The thing about transplants, sometimes you're lucky and the parents have saved your cord blood. It's expensive. And sometimes you don't do it because you can't do it. And sometimes you do it because you know of history in your family. And you're like, oh, let me just save it. It could be used at this time for that hematopoietic stem cell transplant. It doesn't have to be your blood type. It doesn't have to be your relative. Yes, yours is the best, siblings are the next, but it can be from anybody. Now, there's two types, and you need to know the names. So when it's your own blood, like my own umbilical cord blood, automatically mine's the best, autologous. That's how I remember autologous. Automatically, I want mine. That's the best. And then there's all the others, allogenic, whether they're siblings, whether they're from whoever, okay? Autologous, allogenic. Automatically, mine's the best, and then all the others. So, leukemia is going to have that port. They're going to be accessing a lot. They're going to be in pain. They're going to have masks on. They're going to be so immunosuppressed. Their blood counts are going to go low. They're going to be getting blood transfusion, platelet transfusions. They're going to get all sorts of, side effects. Prepare the kid and be there and just be that understanding person. Any one of you who wants to be a pediatric chemo nurse, dealing with cancer, do you know that there's like $25,000 sign-on bonuses around the country for this? Yes. And you're like, oh, I don't want to work with cancer in kids. Well, it's not that they lived or died. It's how did you take care of that child and that family when you were with them? I was talking to Jennifer earlier. I've made lifelong friends of parents of children who have died because of the way I treated them and their child when they were living. So it's very rewarding and it's very emotional. And it doesn't mean you can't cry, because I cried with all of them. Now, the prognosis of leukemia is a lot better today. We know it depends on what was the white count when they came in. Was it 0.1 or was it 0.01? I've seen that one too. How old were they? Was it the ALL or the AML? Male or female? And then the karyotype has to do with blood. If you have a rare blood type, it's going to be harder to get you the products you need when you need it. So treating cancer, we have chemo, radiation, and surgery, and the combinations of all of them. And we know it is very specialized. The nurses need to go through training and chemo and all of those things. As I said, what are those things that we see? Is that pain, fever, the bruising? It could be lethargy, weight loss, and then sometimes it's those enlarged lymph nodes, and we'll go into some of those. One of the things about treatment and chemo, when you get to like day 5, 7, it's called the nadir period, and your neutrophil counts are the lowest. This is when you have to be the most particular on hand washing and good infection control, okay? Now, neutrophil counts aren't just low on children with cancer. It could be any child in your hospital, any adult. So one of the things, if you have a neutrophil count of 500. You have no immune system. Your chances of going into septic shock, crashing and burning, as I call it, is real, and it could happen quick. So if I were to care for a group of patients, I find out one of my patients has a low neutrophil count, and then the nurse's assistant tells me, oh, that patient has 100.6 fever right now. Guess what? That's my number one visit. I want to make sure they're okay. I want to get them on antibiotics, get them started, because at 500, they cannot do it on their own. Their body doesn't have that immune system. So one of the things to remember as we're prioritizing patients. Hemorrhage is there because of loss of platelets and of all the cells. We know they're going to get all sorts of transfusions. We know that when their blood counts are low, they're not going to feel good. They're going to be tired. Today, we give antiemetics before they vomit. Do you know when I started nursing, we had to wait till the patient vomited till we gave an antiemetic. And I'm like, that doesn't make sense. They're nauseous, we should give it. So I'm talking many years ago. So yes, we give it before prevention. Again, nutrition. Their mouths can swell up and they don't feel like eating. So what do? We give them the highest, richest, most calorie, protein, full fat stuff we can, and they just need little bits of it versus a lot of it, right? We know one of the things I saw in some of documentaries is they're really using well the cannabinoids in children. First, I started in Colorado is where it was first looked at. One of the first documentaries I saw. And the children didn't have any nausea and vomiting. And that's what we want instead of these other drugs. As I said, mucosal, it's mouth to anus, all of it can be irritated, so be careful with the foods. And then, of course, neurological. We worry about those things, especially if they, have bleeding things like low platelet counts. They're in pain. They're getting pain medicine. So they have to push down to have a stool, right? So using stool softeners can help. They get hemorrhagic cystitis, and of course, it's that hair loss. I can't tell you how many brothers and fathers cut their hair with the kids so that they're the same. I would just have ribbons and come in every day and make them headbands and took little bows, and I'd put one in my hair and one for them and sent one home to the sister, and it became this fun. So it was like, I have no hair. Well, no big deal. I got cute bows. That was how I had them deal with it. And then, of course, they use lots of steroids. So side effects, Cushing disease, swelling up, feeling uncomfortable, especially the older kids, body image, right? And we know with steroids, it's monitor salt and reduce fluids. So preparing for procedures, number one, you got to get on their level. Let them know what's going on. And then knowing that we're going to put topical stuff on and we're going to do deeper infiltrations. We really, especially like on a bone marrow, they're going to sedate them today. They don't want them to feel a lot of it, but it's not they're under anesthesia. They're just sedated. Pain management. Now, remember, it's not just the opioids. It's not just the acetaminophen or ibuprofen. It's the positioning. It's that distraction. It's all of these things. And it is that we want to titrate and increase those doses to make sure that this child is getting good pain relief, but they're not getting those other bad side effects of all of the opioids. Could be nausea and vomiting, constipation, right? So health promotion today, we know that kids with cancer, don't feel well, but they need to take care of their teeth. They don't want to do that. Immunizations, like, can they get it with cancer? Well, live attenuated viruses are contraindicated. But look at this varicella thing. If they get chickenpox, it's dangerous. So they need to get the varicella immune globulin. That one they need to get because the disease is worse than the immunization. And also, family has to be careful what they do. Now, lymphomas, there's two types. There is a Hodgkin's, which I call the lodge, the house. It's a big one, usually in the upper type of a neck from the shoulders up. So Hodgkin's is a big, thick lymph nodes. And if you can look, it's up like in the neck, shoulder up. And it's Hodgkin's, it's the lodge, it's a house, it's here. You can feel it, you can touch it. Now, and I'll tell you why I say that, because non-Hodgkin's is confusing. So, painless, enlarged, firm cervical or supraclavicular lymphadenopathy. Shoulders up, these lymph nodes, they get big. And what happens is, as they're getting big, they're getting nauseous, it's pushing against the airway, so it could be causing coughing. And then, of course, it is cancer. So that fever, anorexia, weight loss, night sweats, part of it. We do diagnose this with just the normal lab test that we do, x-rays, and then they'll do a biopsy. This one you can do a biopsy on. And this lymphoma, Hodgkin's, has Sternberg reed cells in it, and that shows the cancer. Now, if it's in the neck and it's that big, we want to do radiation, reduce it, chemotherapy to help, and then they'll take and remove, these lymph nodes, if they need to do it. With Hodgkin's, non-Hodgkin's or Hodgkin's, there is high risk for infertility because of the treatment they have to do. So concern, later on in life. Now, non-Hodgkin's is a house. It's a couple little places you can see and feel and touch it. Non-Hodgkin's, not a house, it's diffuse, it's everywhere, okay? That's how I remember that. And as you can see, it's all over. Again, they'll do the biopsy, they'll look at it, and they'll do aggressive radiation and chemo. Again, it goes through induction, consolidation, maintenance, and then intrathecal just to be sure. Now, brain tumors. Brain tumors are common in children. They don't have to be cancerous. They could be benign. Sometimes what we'll see with these is usually the big ones that I hear is headache that's progressively getting worse that wakes you up at night. Vomiting, not related to eating at all, okay? And then, of course, you could go into the swelling, the hydrocephalus, the eyes because of the pushing, ataxia because of the brain. Where is it sitting? Is it on your balance area? It depends on where it is, the signs and symptoms that you're going to see. So, an x-ray, do MRI, find out where it's at, and they do lumbar punctures unless there's too much pressure in the brain, because it'll just squirt out too much fluid and it could cause the brain to drop, which is dangerous. So, brain tumors. First, we like to do and get it smaller. We'll do radiation, we'll do chemo, do the surgery and take it out. And they do big incisions that look like this. That's not uncommon at all. So when we are doing children with brain tumor, of course, listening, signs and symptoms to find out why. Postoperatively, it's all about positioning and fluid balance and comfort. Remember, you don't want to ever give too much fluid, because the brain in a tumor, and you've had surgery, it could open up vessels, cause bleeding, et cetera, et cetera. So being careful with fluid regulation is important. Also, some of these you can lay on the side that has a tumor, the surgery, and sometimes not. You need to know what the doctor wants. And also, Is the head up 15 degrees, 30 degrees, or can you move it whatever? Very important parts of the puzzle. We don't know till after surgery what they want. I'm just going to quickly mention neuroblastoma. It is not common at all. It's a tumor that starts in the abdomen, but by the time it's out to the brain. So it goes from the abdomen to the brain. And usually by the time we find it, it's already metastasized, and the outcomes are not good at all on these children. So again, it's going to be parents and helping them get through it. Now, brain tumors, osteosarcomas. Many times osteosarcomas are in the long bones, like the femur. Femur gets them. And what you'll see is all of a sudden they'll be limping. And it's not just in the morning, doesn't get better, it's all the time. You know, limping in the morning could be the juvenile idiopathic arthritis, right? They're stiff. But with bone tumors all the time, and sometimes you can feel it, that something's going on there. Now, we will do, of course, a history, find out. Usually the doctor will give, especially these kids, give them a dose of ibuprofen. A half an hour later, see if it helps. Because sometimes it's just muscular. If it doesn't work, they're going to be doing the x-rays and they're going to see that fuzz on the side of the long bone. I mean, if they also have a history of anemia, weight loss, infections, and all that, then we know for sure to look exactly for it, and they'll do biopsy. Now, one of the things about osteosarcoma, it is long bones. Many times, as I said, it's the femur bone. You can't take a piece of the femur bone out. You've got to take the whole thing. And that leaves just the knee and the lower extremity. Now, how are you going to attach that? Well, they do. They pick it up, turn it around, and reattach it into the hip socket because they want a place to put some sort of prosthesis. So that's what we call salvaging the limb. Wilms tumor is a kidney tumor. It's a nephroblastoma. It's renal cells that happen, and it is a painless tumor in the abdomen. I had a little 3-year-old boy come over after the 80 earthquake. We had found him down there. A religious group got him to the airport, and they brought him directly into the ER, into triage where I was. And I was like, so what's going on? And they go, I don't know, here's the records. It was in French, so I couldn't even read the record. So I had to do an assessment. Where do you put the kid? In the ER. There's many different places. So I did an assessment. I got on his level. I don't know why to this day. So once we know it is that, it is a fragile tumor. If you manipulate it too much, it's going to break off and it's going to metastasize. And now you've got a problem. So chemo, radiation, and do surgery. And we just take the whole tumor out of there. So preoperatively, there should be a sign on the chart over the bed, plastered on his forehead if you need to. Do not manipulate, palpate abdomen. I mean, 3 years old, probably still in diapers. You got to be careful. And post-operatively, you've got to go through that abdomen to the back. So the bowels and urine function, you must monitor real well post-operatively. There are little tumors, soft tissues that can come from nose, ears, eyes, and they grow, and usually you will have to treat them and then do long-term treatment. A retinoblastoma, Ever see an animal out in the field behind your house and you see those little white eyes when the light comes on your back porch? That is what we call a cat's eye. I've seen only one of these, and it was an 8-month-old little girl who came in, and I was like, oh. And it's you could see just put a light, and it's just this white glow that comes out there. I mean, with the parents, you got to find out has the kid had any other problems going on with his eye, or this all of a sudden happen. They do a radiation, they shrink it down, and they take the whole eye out because it's the retina. They have to, and then they'll end up getting eye prostheses there. Germ cell tumors, testicle tumors, just like women should be doing monthly breast checks, men should be doing monthly testicular exams. Had an 18-year-old boy come in complaining of testicular pain. And I was in the room with another nurse. She examined him. She said his testicles, again, were the size of a softball. And when they did the ultrasound, they did an x-ray of the abdomen and the chest, and he was already full of metastasis. And he died 3 months later because he didn't get checked quick enough. So very real. Liver, the great thing about liver, you take a piece off, it grows back. So liver cancer, we take out what we don't need, what we need to take out and leave the rest. Survival rate has changed over the years, probably even better than 80%. We know there's a lot of things that we as nurses can do and to look for, and just, if we're going to work in chemo to try to keep up with it. Cancer free, those are those Facebook postings that I used to love looking at when I was on Facebook. Any questions so far? All right, who wants to win a Kahoot today? Oh, calm, Keon, you won last week. What's your problem? I think Catherine's in the mood today, or Marie. Uh-oh, Jennifer wants it too. She's getting ready. Hmm. Hmm. Anybody else want to join? I believe there is 50 questions, so let's get her done. Week 6, halfway through, guys. Which statement best describes a neuroblastoma? Remember, that's the one that starts in the belly and goes to the brain. And this is the one, by the time we make a diagnosis, it's already gone from the abdomen into the brain and it's already metastasized. And it's not common. So I didn't go over it too depth. What is priority treatment for a newborn of an HIV positive mother? Remember I told you, just because you're born of an HIV positive mother does not mean that you have to have HIV. And the goal is to improve the immune system. I ask you, what are antibiotics going to do for a virus? Nothing, okay? So it's improving the immune system. What are symptoms of sickle cell anemia? I mean, when we see children coming in with sickle cell anemia, they're usually swollen, hands or feet or elbows or knees, and they're in pain. And remember, they can get sickle cells in the little vessels of their eyes. So it could be vision problems. And then, of course, delayed growth is because lack of blood flow, lack of nutrition to the body and the cells. Sickle cell anemia affects which cell? Which one is it? When you talk about anemia, what are you concerned about? The red blood cells and the oxygen and the iron in it. Yes, red blood cells. I just make sure you know that. What kind of hematocrit would somebody with sickle cell have and why? So it's going to be a lower hemoglobin hematocrit because the cells die really quick. Remember I told you most kids coming in sickle cell crisis have extremely low hemoglobin hematocrits when they come into the ER, and many, many times restart the transfusions in the ER. It's the only time usually it's the sickle cell kids, or of course if they're bleeding. What is the treatment for sickle cell anemia? Number one, IV fluids, dilate it. And of course, blood transfusions. And then in the end, bone marrow. If we can't, it's getting worse. What is the reason children with iron deficient anemia are easily tired? And that's because they don't have red blood cells, which means you don't have oxygen and iron for the body. Aplastic anemia includes a depression of which blood cells? Red blood cells, white blood cells, platelets. That means they don't have iron going around or oxygen. They have no immune system. Their white cells are low and they're bleeding because they have low platelets. They're hit on all different places. What is the most common type of anemia? Iron deficiency. Good job. What causes pernicious anemia? And yes, it's the intrinsic factor or B12 deficiency. Which symptom is the single most common symptom of anemia? Fatigue, absolutely. And then they can't eat and then they're not gaining weight. When teaching parents about beta thalassemia, the nurse informs that the child is at risk for, remember, rectangular cells that die quick and burst. What are they at risk for? So because the cells are dying off quick, they don't have oxygen, so chronic hypoxia, and all that iron's going in. Thalassemia is all about low oxygen and iron in the blood, and it's toxic. So they need to have iron chelation therapy or apheresis going on. And because their cells are dying so quick, they need blood transfusions. Thrombocytopenia is ITP. It's platelets. What lab values will you see with hemophilia? So remember I said with hemophilia, they draw a lot when they suspect it, but initially you're going to see that PTT. Here we are. Let's go next one. Priority treatment for a child with sickle cell crisis is. Remember, sickle cell is the one that the vessels are small and you've got to dilate them. All the other anemias don't need that dilution. It's just sickle cell that needs IV first. Now, as I said, pain medicine's in the other hand, but we're treating, not the cause, only the symptom with pain medicine. We treat the cause by dilating the vessels, and we're going to be given IV fluids. What is immune thrombocytopenia purpura? ITP. P is for what? Following an upper respiratory infection. Treated with what? What to be worried about? So ITP, not enough platelets. What do we worry about, right? Thrombocytopenia can cause the following symptoms. So thrombocytopenia, these children are bleeding precautions because no platelets, you bleed easily, right? It's petechial hemorrhage, ecchymosis, epistaxis, and it's usually that nosebleed is how we figure out that it is ITP. A multi. Child with hemophilia is swollen and the knee is swollen and painful. Treatment would include what? I mean, part of the treatment would be some home factor care, home IV therapy, but we're not going to exercise, it causes more bleeding. We're not giving hot packs because it dilates, causes more bleeding. Cold packs elevate, rice, rest, ice, contain, elevate. And the younger kids that protect that price, right? What is the priority nursing action for a suspected blood transfusion reaction? What's the first thing you do? Well, can they have a, fever, or they're complaining of shortness of breath, or they have a rash? Stop it immediately. Don't ask. So when you talk about a child neutropenic, I mean, there's a low white count, which means you're susceptible to infection. So always, number one is always hand washing. Which symptom would a healthcare professional expect to see in a child with leukemia? And this is the bruising, fatigue, bone pain, fever. These are those symptoms. You're going to do a CBC, see those immature white blood cells, and we start treatment. Your child with ALL has had recent lab results with platelets of 10,000. What is your nursing action? Now, doesn't have to have ALL. Any child with a platelet count of 10,000, what are you going to do? And that's bleeding precautions because they will bleed. Very good. A multi. A child's placed on those bleeding precautions for ITP. What interventions would the nurse do? It's all the bleeding precautions. It's all the above. No injections. No, look for bleeding. Monitor the CBC, the platelets, and then those corticosteroids are given. Child with Wilms tumor, which action by a nursing student causes the faculty member to intervene. So with the Wilms tumor, we do not do even a pre-op biopsy of it because it puts a hole in the tumor and that will create metastasis. So we literally leave it alone. Cancer of the body's blood-forming tissues, including the bone marrow, is called. And that's leukemia. Yes, it is. A child with ALL has a fever of 100.5. What should they do? Any child who's immunosuppressed with a fever of 100.5, what should they do? They don't have an immune system. They need to call the doctor and they need to be placed on antibiotics. And depending on the child, either IV or PO. A child having a bone marrow aspiration, what should you tell the child? And it's going to hurt, but we're going to do everything to make it as little as possible. The most common clinical manifestation of a retinoblastoma. And that's the cat's eye. Remember, it's the retina, and it's got a tumor in it. So it sort of reflects, and it's called a cat's eye reflex. Your child's been diagnosed with a retinoblastoma. What information is important? What history do you want to know, right? I mean, I'd ask, like, when did you first start to see this white in the eye, and how long did it take you to get to the doctor? I don't know how quick they grow. And yes, any sort of history, I want to know about it. A goal of surgery for a child with an osteosarcoma is what? Many of these osteosarcomas are your young adolescents. So our goal is to salvage the limb. Now, you can't just take the tumor off. You have to take the whole femur bone out, which means the whole upper leg is gone. So we want to put that bottom leg up into that hip joint because we want a place where they can put a prosthesis and walk. True or false? Immunizations causes autism. Absolutely not. That was a falsehood that came out, and that physician doesn't have a license anymore. A child's complaining about skin markings for radiation therapy should be told. Now, especially for when you have the retinoblastoma, they take and put these purple marks, and that's where they direct the radiation ray. If you wash them off, then they don't know where to point the radiation and they have to do the measuring again. You have to leave it alone, leave it there until they're done with radiation. Multi. Nursing care of a patient with immune thrombocytopenia purpura. And we're going to be given IM injections, monitor CBC, corticosteroids. Now, why would you give IV fluids to a person who doesn't have platelets? You don't have little vessels. You don't have clog ups. It's just you're bleeding. So IV fluids is for sickle cell. It is not for ITP. You don't need it, okay? When distraction is used, it helps to do what? When you take and you distract the child, the younger kids, and the older kids don't work as well, but there's ways to do it. But they forget that they're hurting. Give them something else to focus on. What assessment question needs to be asked to a child with possible rheumatic fever? If you notice, I will give you questions from last week. These are just making sure you know that concept. Rheumatic fever is caused by a strep throat that wasn't treated properly. As we go forward, we're going to find one in the GI land called acute glomerulonephritis. Same thing, strep infection. Signs and symptoms of asthma. Remember when you talk about croup, it's all inspiratory. Epiglottitis, which is croup gone worse, which is epiglottitis, all inspiratory upper. Asthma is down and it's expiratory, okay? Expiratory wheezing is always asthma. That's how you tell the difference. A multi. What symptoms should be reported to the healthcare provider for a child with sickle cell disease? So headaches, chest pain, and I think maybe the question should be worded like, what's more of an urgent or a priority? And we know it's the headache because of stroke and the chest pain because it could be, an embolus of some sort going on. Yes, swelling of the hands and feet are one of the symptoms, but the other two are the ones that are like emergent. Absolute contraindication of nasal tracheal suction include which of the following? As in, what are you putting that in the mouth for? And it's everything. You have epiglottitis, you're already swelling. You have croup, if you leave it, it turns to epiglottitis. Let's make some more swelling in there. And of course, tonsils. Leave it alone. We could cause bleeding, and it can bleed a lot. Iron dextran is given via which route or route? And that's IMZ track because it burns and it will stay in the skin. So we want it to stay in. A child was to receive their own bone marrow. This is called a what transfusion? How do you remember that one? Automatically, mine is the best. And it's all the other people. Mine is automatically the best. All the others is allogenic. What cancer may present with painless, firm, and enlarged cervical nodes? Remember, from the neck up. And that is your Hodgkin's lymphoma, because it's the house that you can feel. When teaching about sickle cell disease, you would include what? So absolutely dress warm. Again, you want to keep those cells dilated as well as you can. You're going to get fluids like crazy. Pain medicine with early symptoms, absolutely. And that fever, again, they're immunosuppressed. They need antibiotics as soon as you can. Thalassemia major, Cooley's anemia, is treated primarily with what? It is blood transfusion. Now, thalassemia is rectangle cells, the red blood cells, and they burst, spewing iron into the body. They're on iron overload, okay? So, no, not a high iron diet. Iron chelation, apheresis, and blood transfusions. A multi. What are opportunistic infections of HIV? You know, one of the most common ones that opportunistic is PCP pneumonia, pneumocystic pneumonia. Now, Candida, how do we treat that? We take especially on the infant, they get that a lot as infants. We take that nystatin liquid with a cotton swab and just swab the mouth. They can't swish and swallow, can they? They have to have it done for them. Cotton swab, put it in a medicine and swish it around their mouth and their tongue. Multi. Treatment of osteosarcoma includes its amputation or salvaging the limb is our goal. And yes, it's going to be chemotherapy, and stem cell transplant will do nothing. It's not what this needs. That's your leukemia. A multi. Who are the best donors for bone marrow transplantation? We know yourself is the best, right? What did I tell you is the next best? And that's your siblings. Now, can mom and all those do it? Maybe. But your best is first yourself, and then your siblings, made from the same mother and father. Those are the second, and then everybody else. What is the most common opportunistic infection for children with HIV? And that's the PCP pneumonia. What would you consider to be a neutropenia or a low neutrophil count in children? Well, you sort of have to know what the normals are, right? Your normal counts are 1,200, 2,400. They're about right there. If we see less than 500, remember, especially if they have a fever, these children are ready to go into septic shock. Their body does not have any immune system to take care of any infection. Less than 500. That's your sick child for the day. A primary characteristic of a brain tumor is and that's the symptoms are getting worse over time. A headache that was occasional, now it's waking up at night. Occasional vomiting, now vomiting all the time. Remember, not related to eating at all. And it might be being unsteady balance and falling over. That might be one of those things that you would see with a brain tumor. The optimum treatment for an osteosarcoma is Optimum. What's our goal? What do we want more than anything to be able to have? And that's to salvage the limb. We don't want to amputate it. We can't just remove the tumor. You have to have the whole bone gone because the cells are in the bone. So salvage the limb. We want a place to put a prosthesis. So the induction of chemotherapy. What does that mean? And that's the initial intensive 4 to 6 weeks, right? Of multiple chemotherapy agents, and the goal is remission. And then there's another 3 steps just to make sure all the cells are gone. So the cancer will be gone. You'll be in remission. Let's see how we did. Lolita, good job. Number 3. Number 2, Jen. Good job, Jen. Number 1. Jen. And Paige and a JA. Oh, that was fun. So, anybody have any questions, comments, concerns? Remember to be ready for your exam next week. Try to be here just a little bit earlier so that we can get it up and running. So, be out on time, all that good stuff. And if anybody wants to go over their review before your test, just let me know. I'm always available. Thursdays are usually a great day for me to do that, or Tuesdays. So just let me know. Have a great evening, guys. Let me know your pediatric assessment project.